Today we'll discuss about the interpretation of ANA. So generally in our day-to-day OP and IP patients we'll see a lot of ANA reports. We don't know how to interpret them. What is 1 plus, what is 2 plus, what is the dilution, what if it is a patient has RO positivity, what is the significance of all these ANA positive reports, how do you interpret them actually. So before going into ANA interpretation, you need to understand one thing. This is taken in American College of Rheumatology. We use AN as a popular initial test to evaluate lupus. More than 99%, at least 95 to 98% of patients of lupus have ANA positivity. But however, only 11 to 13% of patients with actual ANA positivity have lupus. So this means only 11 to 30% of people with positive ANA have lupus. That means many people who have even though are ANA positive doesn't mean they have some CTD or something. They have actually normal healthy individuals. So you should always keep that in mind. So most of them are normal actually without any symptoms. Maybe they are normal healthy individuals. Maybe they have false ANA positivity reports. So we'll go into the conditions where ANA is positive and all. Generally in SLE, 99 to 100% of patients will have ANA positivity. Only 1% or 1 to 2% patients will have ANA negativity. Even if ANA negative patients will have anti-Rho or anti-log positivity in them. In it comes to scleroderma, it is 97% of patients with scleroderma has ANA positivity. So polymyositis will have 40 to 80% of patients will have ANA positivity. Sjogren's will have 48 to 96%. Especially these three conditions, drug-induced lupus, autoimmune hepatitis and mixed connective tissue disorders, these will have 100% ANA positivity, these three conditions mainly. And also in which may be useful in prognosis, especially in the case of JAA, APLA, Raynaud's. Maybe they are not positive. In the case of APLA, maybe they are not positive in all conditions. Only 40 to 50% ANA positivity is there. But they'll tell you the prognosis. They will tell you poor prognosis. It involves other organ involvement is more. In JAA also, it is more poor prognosis if ANA is positive. So just because the patient has some CTD like APLA, some patient have Sjogren's, that doesn't mean all of them are ANA positivity. So only, especially SLE, you have 99% of positivity. In the case of Sjogren's, vary from 48 to 96. Like 30-40 people are not actually ANA positive. They might be ANA negative also. That doesn't mean they doesn't have Sjogren's. So always ANA should be interpreted in the background of clinical background. So before you send an ANA test, because only as I mentioned before, certain only 11 to 18% patient of ANA positivity will have lupus. So that depends on the titer also. Maybe the titer where they took is less than 1:40 or something. I'll mention what is the titer significance later. But before sending ANA result test or something, you should need to have pretest probability. So before you send an ANA report, you need to have what is this pretest probability? What is the probability this patient might have CTD? Like the patient coming to you with complaint of fever, joint pains, hemolytic anemia, thrombocytopenia, there is a high pretest probability. So you expect the ANA to be positive. Let's say the patient is having malignancy, you send an ANA positive, ANA report, it comes back positive, that doesn't mean anything. So because malignancy can cause false positivity ANA. Let's say the patient is having infective endocarditis, some hepatitis B related disorder. You are sending ANA, it might be falsely positivity. So always send it a pretest probability. Always you need to have some clinical symptomatology to raise a suspicion of CTD. Some fever, some joint pain, some serositis, some ITP, some hemolytic anemia, some lupus nephritis, some neuropsychiatric manifestation. So if there is a strong suspicion, if there is a pretest probability is high, you send an ANA. If it comes back negative, that indicates a clinical diagnosis, that indicates a diagnosis of CTD. We are sending for any random patient like malignancy, some heart failure patient, you are sending ANA, it comes back positive. That doesn't mean anything. So because false positivity is also there in ANA, that is why you should always send ANA report with pretest probability. That is what I am trying to tell you. So this DLA, discrete lupus erythematosus, which is also autoimmune, but 5 to 25% is only possible. Rheumatoid arthritis, 30 to 50% patients of rheumatoid arthritis will have ANA positivity. Multiple sclerosis patient will have 25% of ANA positivity. Thyroid disease patients will also have 30 to 50% of thyroid patients are ANA positive. That doesn't mean they have CTD or something. So patient with silicone breast 15 to 25% will have ANA positivity. Infectious diseases and malignancies can also have false ANA positivity. And also this relatives of patients with autoimmune disease. Some patient will have SLE relative or autoimmune thyroid. They will also have 5 to 25% of positivity of ANA. That doesn't mean anything. Always you have pretest probability. What is the probability of this patient might have CTD? Only with that probability you send an ANA report. Then you'll understand and you'll interpret it better. So and also when you send an ANA report, always a gold standard screening parameter for ANA test is immunofluorescence. First you send immunofluorescence, not ELISA, not anything. Immunofluorescence is a gold standard screening test for ANA. So in ANA you'll get, in immunofluorescence report you will get two things. One is the intensity, that is 1 plus, 2 plus, 3 plus, 4 plus. Anything 3 plus, 4 plus is significant. And also you'll get the pattern. It is homogeneous pattern or speckled pattern or dense speckled pattern or rim pattern or nucleolar pattern. Whatever, you get different patterns. Based on that pattern you can tell what kind of disease. If it is a homogeneous, maybe SL is a possibility. If it is speckled, Scleroderma is a possibility, Sjogren's is a possibility, SL is a possibility, myositis is also a possibility. If it is cytoplasmic pattern, myositis is a possibility. So based on the pattern, you can tell what kind of disease might be there in the onset. So but you always interpret it. Let's say the patient is having cytoplasmic diffuse pattern, the patient doesn't have any myositis symptom. You don't go ahead and send myositis panel and all. So always in the background of myositis, if the patient has myositis, if you are finding diffuse pattern, diffuse cytoplasmic pattern, you send for myositis antibodies. So always first the pretest probability. What is the patient pretest probability should always check. So this is one thing, intensity, pattern, then you find dilution titer. So at 1:40 dilution titer, 20 to 30% of healthy individuals will have positive ANA. So this is a very false high, positivity is very high. So they took it to 1:80 titer. That came down to 20-12% of healthy individuals are only positive at the rate. So most of the ACR ULR criteria for classification criteria for SLA all use 1:80 as a dilution titer, minimal titer where it should be positive to label it as SLA related ANA or something. Like ANA is positive for SLA. 1:160 is more significant. Like 1:160 or dilution, only 5% of healthy individuals are positive at this dilution titer. So anything more than 1:80 as per ACR ULR, anything 1:160 is more significant. You're getting at 1:160, it is more significant that patient is having some underlying CTD because only 5% of healthy individuals will have positivity at 1:160. If you are going at further level 1:320 or something, only 3% individual. So this is very important in the interpretation, at least 1:80, especially in the case of ACR ULR, and 1:160 generally what we take in our day-to-day practice. But that is false. You can decrease the false positivity at these titers. So 1:40 they are not, especially you can interpret them in pediatric, but elderly especially 1:80 or 1:60. In pediatric 1:40 also might be significant in few cases. So this is one more important thing. So healthy individuals, usually older and female people or relatives of people with connective tissues, may produce false positive NA at a frequency sometimes exceeding 30%. Although these people often possess titers of less than 1:320 with homogeneous or dense speckle. Generally you find dense speckle or homogeneous pattern in them. But if you dilute them more, they may be positive at 1:40, but you dilute them to 1:160, 1:320, they lose their positivity. Their intensity will decrease and they lose their positivity. That's one more way you can interpret a false positive ANA or something. So that is one more thing that is important. In the same way, SLE might have false negative ANAs also, but if you send an extractable nuclear antigen, generally if ANA is negative also, generally Rho or La is positive in the ANA negative lupus. That is one more thing I want to highlight. So the gold standard, as I told you, screening is always immunofluorescence. In that you will find three things. One is intensity, 1+, 2+, 3+, 4+. Anything 3+ or 4+ is important. And the pattern, homogeneous speckled nuclear pattern that there. And dilution titer. Anything more than 1:80 as per ACR ULR. And 1:160 is what we take significantly positive. So other tests like ELISA or non-immunoabsent, all these are all, they can cause falsely positive and have lower accuracy. They should not be used for screening. First you send an immunofluorescence, after that only you send for immunoblot or something. So these are the various pattern I told you. In the case of homozygous pattern, generally homogeneous pattern, generally you see most of them are related to dsDNA histone antibodies. So this is mostly SLE. If you are finding homogeneous pattern, then you will evaluate for SLE because that's suggestive of SLE pattern. Always in the background of clinical background, always you should have the clinical picture of some fever, joint pains or lupus nephritis, then you will work up. If it is not there, generally if clinical background is not there, that might be a false positive case. So speculatively you can find it in the case of SLE due to SM or UNRNP, in the case of systemic sclerosis, in the case of RNA polymerase 3 or UNRNP, you can find it in the polymyositis dermatomyositis. So this pattern may suggest which kind of disease might be there. So if it is there or not is a clinical discussion. So it guides you in the treatment. It doesn't mean you have to definitely give the treatment with these patterns and all. It will guide you. So it will guide you. This might be a possibility, but whether it is there or not, it is based on the clinical picture. So discrete speckled, it is due to centromere pattern. It is seen in the systemic sclerosis. Diffuse cytoplasmic, as I told you, in the case of myositis, where you use anti-Jo1 antibodies and all. So this is how you interpret the pattern. I'll discuss about every disease separately, and then I'll discuss more specific antibodies. How are they, why are they useful, how do you interpret them and all. But I'm giving a brief idea of what is this and all. So this is how. If you are suspecting, first you suspect an ANA, autoimmune disease, then often immunofluorescence related ANA. Immunofluorescence ANA. If it is negative, so then you can consider testing for if it is if you have high testing, you test for other conditions and all. Let's say if the patient has low titer, low clinical suspicion, you suspect for other cause, any malignancy or infections, you test for other. If you have high clinical suspicion, so if you are having high clinical suspicion despite of having the low titer, then you check for extra nuclear antibody, extractable nuclear antigens, especially dsDNA, UNRNP, SM, Rho, La. These are all extractable nuclear antigens where you check for their antigens whether positive or not. So based on the symptom, that also what extractable nuclear antigens you should check for, that is also based on the symptomatology. So let's say ANA is low titer, it is not significantly positive, but you have clinical suspicion is more. So if skin and joint involvement is more, so skin and joints are generally involved in the case of SLE. One is SLE, one is Sjogren's, one is scleroderma. So on mixed connected tissue, you send for those extra nuclear antibodies. So these are the four or five antibodies you can done. Let's say drug exposure is there, you send for antihistone antibodies. Let's say the patient is having Raynaud's phenomenon, sclerodactyly, and myositis, and clearly CREST syndrome or scleroderma is there. You only send for anti-SCL70, anti-RNA polymerase, and you don't send for a whole blot in them. So based on the symptomatology, you send what kind of extractable nuclear antigen that is there. So if you are having skin and joint alone, you need to send for SLE and Sjogren's and all things. But because it is a more broad marker, if you are having Raynaud's syndrome, you go ahead and directly do only scleroderma markers like SCL70, RNA polymerase 3, and centromere, or C1RNP, which is an MCTD marker. Or this is a myositis, if you are suspecting myositis and ILD, you only anti-TNA, that is anti-Joan. You go and directly go as polymyositis and dermatomyositis. If you are having Zika symptoms, you do anti-Ro and anti-La. So that is how you do. Based on the symptomatology, you do antibodies and interpret based on them. So you don't go reverse, like you get an antibody positive, then you go and diagnose something. So if you have symptoms, you send a test because the pretest possibility is high. If this is positive, that means that patient has SLE. Just because these antibodies are positive, that doesn't mean patient has SLE. They can be false positives also. Always, if patient should have some symptoms to diagnose it as an SLE or something. That is what I mean to say in this case. So always, this is one more point I want to hold. All rheumatological diseases are not diagnosed. They are all classification criteria. So you can see 2019 EULAR ACR classification criteria for SLE. Why they named it as a classification criteria? Because rheumatological condition is a continuum. They are heterogeneous disorder which are a continuum disorders. So most of them, if you go to scleroderma, you will obviously find fever, leukopenia, trauma, like you will find fever, joint pains or something. If you go to Sjogren's, you will find fever, joint pains. They are all constitutional symptoms. So they are not definitive, like these are all not specific or definitive for this thing, except in the case of renal biopsy or something. They're not definitive or gold standard for diagnosing SLE or something. So it is a continuum of disorders where you need to classify based on the symptomatology. It is classified as SLE. So if the patient is having Zika symptoms, it is more likely the patient has Sjogren's syndrome. So they will also have fever, joint pains, leukopenia, thrombocytopenia. It is there in SLE also. So none of them are defining our gold standard features to diagnose the SLE or to diagnose Sjogren's or something. So these are all more of classification criteria where you classify. So today this is having fever, leukopenia, thrombocytopenia, it is filling SLE. Maybe the patient will have scleroderma patient symptoms until then will SLE scleroderma overlap or something. So that is how it works. It's more of classified based on the present day symptomatology or classifying it as SLE. So these are all continuum of disorders where they have symptom is not definitive for this. This might be present in the other diseases also. So that is why based on the present day symptomatology you classify it as per this. So if you have more of Zika symptoms, you classify it as Sjogren's. If you have more of Raynaud's phenomenon and sclerodactyly and esophageal dysmotility and also skin thickening, you might have scleroderma. If you have more of lupus nephritis, cutaneous manifestation and skin and joint pains, you label as SLE. So this is how you label it as. So based on the symptoms, they might be classified. They are not diagnostic criteria, they are classification criteria. Because at some time the MCTD at present can convert into SLE someday. So that is how it works. It's a continuum, it's a more of heterogeneous group, that's why. So they're all classification criteria. This is also classification nomenclature. These are all classification criteria. They are not diagnostic criteria. They are classification criteria. So that is what. How do you classify? How do you? I'll discover separately everything. I'm not going to say what is the criteria that is present in them. You'll always read about it. But I want you to understand this here also. Positive NA titer at least 1:2 is the obligatory criteria. I mentioned what is the titer that is significance is also important. So this is how you classify the SLE. It's all classification criteria. So this is an immune blot. So after you send an immunofluorescence, it is positive. So you are suspecting. So ANA is positive because you have the patient, let's say the patient has some fever, some ITP is there. So you are sending ANA immunofluorescence, it is positive. So then you send for extra nuclear antibodies based on the, generally you can send whole immune blot, you are not finding any specific feature. But if you are finding specific feature, like if the patient has fever, joint pains, then you only send for dsDNA, anti-Smith, anti-UNRNP, anti-Ro, anti-La, because Sjogren's, MCTD and SLE are the more common things. If the patient is having myositis, you only send anti-MI2 alpha, anti-Jo1 and all. So there are few myositis panel that only you send. If patient is having scleroderma feature, you only send anti-SCL70, anti-centromere, PMSEL, those things only you send. So if you have definitive these features are only there, you send only them. But if you are not finding any other cause, you send whole immune blot. So in immune blot, you will find two things. These don't have any titer or something. You will find negative, positive, plus. So what is generally negative is negative. So this 1 plus can be normal also. Normal people also might have 1 plus. This is not significant. Anything more than or equal to 2 plus is significant in them. So anything more than or equal to 2 plus might be significant. In this case, there is NM, NRNP, SM. This is suggestive of MCTD. So if SM is also positive, that might be SLE also. Like I'll tell you what is DSDNA is SLE, nucleosomes may be there in SLE, histones may be seen in drug-induced SLE, SSA, SSB may be present in Sjogren's also, and also sometimes ANA negative lupus also. RNPSM is MCTD, SM is SLE seen in SLE, MI2Q, these are all myositis, these are all myositis panel, these are all till PML, they are most myositis panel. SCL70 is again scleroderma. So these are all you need to remember. So based on that, they are more specific for certain diseases. So DSDNA is specific for the SLE, and nucleosome might be seen in the SLE also. Rho52, Rho are more likely suggestive of Sjogren's syndrome. Mi2 alpha is more suggestive of myositis. So anything more than or equal to 2 positive, 1 plus might be normal also, more than or equal to 2 plus is what we consider significant. This is done by immunoblot. So this is the extranuclear. Like after ANA immunofluorescence is positive, then you send for this all these antibodies, and these are done by immunoblot. You can also do ELISA also. So ELISA will give you more quantitative titers, especially it is done in the case of DSDNA. So in DSDNA, if you need to correlate the disease activity, generally DSDNA titer will correlate with the lupus nephritis activity and vasculitis activity in the SLE. So in them you do ELISA, you will get proper titer. Based on the titer, you will understand how much disease activity is there. So these tests, whatever DSDNA, UNRNP are general by immunoblot, where you want to diagnose. If you want to know the proper disease titer and activity, you should send for ELISA. ELISA will give you titers. So here you won't get any titers or something, you'll get positive, you won't get any dilution also. Anything more than or equal to 2 plus is significant. So this is how you do it. So screening for ANA can be valuable when there is a clinical suspicion. This is most important. You have clinical suspicion, then you should need to do. ANA screening is performed by indirect immunofluorescence. Indirect immunofluorescence is a gold standard screening test. So it will tell you about different patterns, it will tell you about intensity also, it will tell you about the anything more than 3 plus intensity is significant. Titer also, anything more than 1:8 is significant. So dilution 1:8 is positive, are further 1:8 is second stage significant. The higher the titer where the positive can still be detected, ANA screen, the more positive the test is. Generally, if you are going into more dilution, if it is still positive, that means there is significant CTD present. There is some CTD suspicion increases more. So autoantibodies to multiple ANA, a number of like these can be frozen DSDNA based on the symptomatology. If ANA is immunofluorescence is positive, based on the clinical symptomatology, you can send DSDNA or SCL70 based on the symptomatology, or else you send the whole immune blood if it is non-specific symptoms appear. Based on the symptoms, you can tell what kind of disease might be there. Like in the previous report, in this case, NRNP-SM is there. More might be MCTD might be positive. You go and ask for MCTD. So if it is there, it is there. Otherwise, you will just follow up the case in next 1 year or something. You will again ask for symptomatology. You will again repeat the report and observe. So you don't go ahead and treat MCTD because the patient doesn't have any symptoms. So all positive will undergo additional testing for anti-DSD and anti-extractable nuclear antigens. If these are positive, patient be reviewed, and generally if ANA is positive, then you check for extractable nuclear antibody antigens like I told, and also anti-DSD. If they are positive, they definitely have some rheumatological condition. If they are negative, if they doesn't have any symptoms, generally the patient can be put on follow-up. So this is so. Where there is a strong clinical evidence for ANA tests are generally ANA tests are negative. So generally, if the patient will have significant, like the patient is having clinical suspicion of ANA is more, like if your patient is having fever, joint pains, and ITP, but ANA came back negative, that is very unlikely. So you can repeat the test again, or sometime you can label it as ANA negative lupus, in which case Rho and L are positive, Rho and L are positive. So always clinical suspicion is always important. Where there is clinical evidence is there, always reevaluate the case thinking about CTD. But if the clinical suspicion is not there, ANA is positive, then you can just follow up and see. So if ANA titer is less than 1:6 significant, it considers weak ANA positive. So it can occur in variety of conditions, as I told you. If ANA is 160 or greater, but DSDNA antibody are negative, and the patient has no signs of connective tissue, there is a reduced likelihood of connective tissues. So let's say a patient is having ANA 1:160 titer, it is more than positive, but DSDNA and extractable nuclear antibodies are negative. That doesn't mean that patient doesn't have any symptoms of CTD. So the patient is unlikely to have CTD. Just because ANA is positive, that doesn't mean patient has CTD. So both extractable nuclear antigens and DSDNA both are negative, and patient doesn't have any features, so that is unlikely to be CTD. So you can consider reevaluating after 1 year based on the symptomatology and all. So always first do in a patient, always ask for the clinical history. You need to have pretest probability. Then you send an ANA immunofluorescence. So anything more than 1:80 titer with intensity 3 plus or 4 plus based on the pattern. So after if ANA is positive, then you ask for the what kind of disease you are going to do. So if the patient has sclero, based on what symptomatology, Sika symptoms, we will evaluate for Roanla, for joint pains and skin, you scan for SLA antibodies, scleroderma symptoms, you ask for joint. If it is not there, you send for all them. If these are positive, it is likely to be a CTD. If these are negative, but patient still have symptoms or something, you need to re-evaluate them by different method or something. If patient has symptoms, always recheck the test and re-evaluate the test. Patient symptoms are there, most likely it is CTD only. If ANA is positive, most likely it is a CTD only. If even extractable nuclear antibodies might be, generally they will be positive, might be sometimes be negative. If ANA is positive and some symptoms are there, they will definitely be CTD, even though extra nuclear antibodies are negative or something. But if ANA is positive, extract nuclear antibodies are negative and symptoms are not there, then it is not CTD. So you can just follow up the EPSI in 1 year. So this is what I want to tell you. Thank you.